We're going to touch here on one of the more common manifestations of allergy in the general population. So here we have an 8-year-old boy coming in with his mother complaining of a runny nose and fatigue over the last several days. It caused him to miss a school field trip yesterday. His mother says that he experiences these problems to one degree or another throughout the year, but it gets worse in the springtime. On further questioning, it is revealed that he has significant nasal and eye itching, and occasionally has redness and tearing of his eyes, especially during the springtime. Occasionally, symptoms will remit with the use of children's Claritin, which is loratadine, a second-generation antihistamine. Birth history was normal. He is one of 3 children. He has 2 younger sisters, one of whom also has similar symptoms, but not quite as severe. The patient is afebrile. On physical exam, you note mild darkening beneath the lower eyelids and a transverse nasal crease. Sinuses are painless on palpitation and percussion. Lungs are clear to auscultation. Rhinoscopy reveals a pale nasal mucosa with some clear discharge. So obviously the diagnosis here is what we're looking at, the name of this lecture, which is allergic rhinitis. Now, why do we suspect allergic rhinitis? Why is this a classic case of allergic rhinitis? Now, definitely without doing, this is a clinical diagnosis, but without doing other tests, you can't definitively 100% say this must be allergic rhinitis, but given the absence of other symptoms in this patient and the otherwise normal history and physical examination in this child, it's very difficult to suspect anything other than allergic rhinitis. So first of all, we know that the chief complaint is runny nose. Now, runny nose can be a lot of things. It can be a viral infection, for instance, upper respiratory tract infection. It could be the flu. But we don't really see any other problems with this child. This has been going on for a while. However, this is something that it happens episodically, or there's a baseline persistence of these symptoms throughout the year. So this isn't something that is suddenly new. It's an exacerbation, but it's not something that he was totally fine and now suddenly he's got this brand new rhinitis, this brand new runny nose. That's not the case here. He has this chronically. We also see that in addition to the rhinitis, in addition to the runny nose, he also has some ocular symptoms as well. So he's got this eye itching and occasionally redness and tearing, and that also follows a similar pattern to this runny nose. The runny nose, it's a problem throughout the year, but it gets worse in the springtime. Same with the redness and tearing of his eyes. That gets worse in the springtime. We also see that this patient has symptoms that occasionally remit with the use of an antihistamine. And this is going to be classic when you go into a patient's history, and this is always important, to go into a patient's history and ask what makes this better or worse. And if you were to ask this patient what makes it better, we do find out that the use of an antihistamine, such as Claritin, makes it better. Not all the time, but it makes it better in many cases. And if you were to ask this patient, go further into the history, does anything make it worse? You may find out that being outside for long periods of time makes it worse. Maybe going up to Aunt Martha's house up north where there's birch trees, that makes it worse. Or being around a friend's house who has cats makes it worse. So you may find things like that. As far as family history, we see that there's a sibling who has similar symptoms. That is significant. Allergic disorders tend to follow in families. And then on physical exam, we note our typical child with allergic disorders. So there's the allergic shiners, which is this mild darkening beneath the eyes. If you were to look at this child really closely, you would probably note the Denny lines underneath his eyes here as well. They're not super prominent, but this is kind of a low resolution picture here. And then the transverse nasal crease is quite classic as well for allergic rhinitis. we can rule certain things out. This is not an upper respiratory tract issue. There's no sinusitis, or at least no sinusitis that we can pick up on physical exam. There's no abnormalities in his lung fields. And then when we look with rhinoscopy, you can either use a specialized tool for rhinoscopy, or you can use your otoscope to get a crude visualization of the nasal turbinates. You note that the nasal mucosa is pale and there's this clear discharge. And that's important too, because as we're going to see with allergic rhinitis, the discharge is clear. Whereas if the patient were to have a viral infection or a bacterial infection, the discharge tends to be more mucousy or purulent in nature. We're going to take a look at the background and epidemiology of allergic rhinitis. We'll also talk about the pathogenesis. A lot of this should make sense to you if you've watched my 2 lectures on general allergy. We'll talk about the clinical manifestations, a lot of which we just saw in this vignette. We'll talk about how you go about diagnosing this, which is primarily going to be how you go about excluding other things that may present similarly. We'll talk about the management and then the complications and prognosis. So allergic rhinitis is an allergic inflammation of the nasal membranes, which affects between 10 and 20% of the U.S. population. That number is very difficult to pin down. If there have been studies that came out that asked patients, have you experienced these symptoms at all, allergic rhinitis symptoms, and actually it was about 35% said yes, but when we narrowed it down to have you had these symptoms for more than 7 days at a time, or 7 days during a month, that number went down to about 17%. So it really depends on how you pose the question, but what we do believe is it's about 1 in 5 to 10 people in the U.S. have allergic rhinitis. This is understood as a chronic respiratory disease in children, and the reason for that is not only its high prevalence, but its detrimental effects on patients' quality of life and the comorbidities, the other disorders that we see with it, which also have their own detrimental effects on quality of life. Allergic rhinitis has caused 824,000 school days to be missed every year. That's an estimate. Obviously, we can't get a perfect number on that, but roughly 824,000 school days are missed per year, to say nothing of how this affects adults. It also causes approximately 4.2 million days of decreased quality of life per year. So you can see that this is a major quote-unquote epidemic that we have here with allergic rhinitis. There's also a comorbidity with other atopic diseases, so things such as allergic conjunctivitis, vernal keratoconjunctivitis, asthma, atopic dermatitis, as well as a comorbidity with other upper respiratory tract disorders, things such as sinusitis and acute otitis media. And we'll see that allergic rhinitis, in and of itself, being an inflammatory disorder that affects the upper respiratory tract, can increase your risk for those disorders. So it helps when understanding allergic rhinitis to understand it, to understand what the purpose of the nose is. And the purpose of the nose is to filter, humidify, and regulate the temperature of inspired air. And this is accomplished on a large surface area that spreads over 3 turbinates in each nostril, so 6 turbinates. And when you have such a high surface area, you have a high likelihood of having allergens lodge themselves in that surface area. So we have the nose essentially acting as a filter. And what are some of the things that you filter out from the air? You filter out high particulate molecules, you filter out allergens, smoke, other things such as that. So these irritants, including allergens, can cause rhinitis. And with allergens, because this is an allergic response, that rhinitis can become very long-term with repeated exposure. All right, so without going too much into the pathophysiology yet here, allergic rhinitis can be characterized as seasonal or perennial. That really goes for any kind of allergic disorder. It really depends on what the patient is allergic to. So things that are more outdoor allergens, classified that way, would be things like mold, could be weeds, could be different trees and pollens that are in the environment. And then there's the perennial variant, and typically the things that cause the perennial allergies are going to be the things that you're exposed to year round. So things that are indoors, like house dust mites and animal dander and fur, things such as that. Now that doesn't fit a perfect rule, as you probably saw if you watched my lectures on general allergy. Certainly if you're living in the southern United States, in areas that are warmer, you're going to be exposed to tree pollen year-round. You're going to be exposed to mold year-round. So if you're working in the northern climates where you have seasons, then you tend to see this more seasonal cycle of symptoms. Whereas if you're working in a warmer climate, then it's hard to rule out your outdoor allergens if you have a patient who presents with perennial allergy. Now we know that allergic rhinitis, in addition to all our other allergies, are increasing in prevalence, and this is particularly in developed areas, and we don't really know why that is in particular, but we do know that more rural areas and lesser developed areas are spared from this increase that we see in these allergic disorders. So we know that patients who live in developed areas, who grow up in developed areas, are almost twice as likely as the general population to have, in particular, allergic rhinitis. The diagnosis of allergic rhinitis is usually established by 6 years of age. However, if for one reason or another they just don't come in very often, or they don't come in complaining of these symptoms, it can very easily go under the radar for some period of time after. Risk factors for allergic rhinitis include a family history of atopy, in other words, just allergy in general, serum immunoglobulin E of more than 100 international units per milliliter before age 6. Yeah, right, like we're ever going to have that on our chart. That would be nice, but usually if you have measured a child's immunoglobulin E, then you've probably already established the diagnosis at that point. Early introduction to food or formula. We generally recommend introducing a child to food around 1 year of age, but if they were introduced earlier, or in other words, when we say formula here, if they were not breastfed, they're more likely to develop allergy. Maternal smoking, not sure why that is. Heavy exposure to indoor allergens. This is why it's going to be important to get a good history on the environment the child grows up in or has grown up in. And then delivery via C-section. The theory there is that when a child crosses the birth canal, they're exposed to flora from both the birth canal and then the fecal flora as well, and that can have a protective effect on ultimately developing these allergic disorders. It has been postulated, and some studies have shown that being exposed to pets actually has a protective effect. And that almost sounds kind of paradoxical, because we know that pets themselves can be the trigger of allergies. So I guess more research is needed to figure out why that is. All right, so just if you hear me kind of shivering, the room I'm in is about 60 degrees right now, so I'm kind of cold. I should probably grab a blanket while I talk to you here. But anyhow, the pathogenesis of allergic rhinitis is really just the same as our pathogenesis of any allergic process. So as an allergic reaction, allergic rhinitis involves a period of sensitization in which the patient is, over a period of time, exposed to the allergen. That they don't need to be constantly exposed, but they're exposed for some time before they ultimately have this priming of their inflammatory cells, which are then coated with allergenic IgE. Ig and receptors, I should say, and then that repeated exposure to that allergen will then set off an allergic cascade, which results in inflammation and symptoms. So we just have a type 1 hypersensitivity reaction going on here. All right. So what are our clinical manifestations? Patient will typically complain of a runny or stuffy nose. So the runny nose is just because of the nasal secretions from the inflammation, from the allergic process. The stuffy nose would be due to edema. So it's not a one or the other. You can have both. So the edema resulting from the inflammation can obstruct the nasal passages. That's going to result in that symptom. And then the runny nose is just because of excess secretions because of the hypersensitivity. Those symptoms may or may not wax and wane with the seasons. It just depends on the allergen that they're sensitive to. This often coexists with nasal pruritus, in other words, just itchiness of the nose. This should be distinguished from itchiness of the skin over the nose. This is a sensation of itchiness within the nose. There can be sneezing, there can be coughing because of postnasal drip. They may have difficulty breathing at night, and usually the symptoms are worse at night. And a lot of times this can lead to sleeping trouble. It can also lead to sleeping trouble if they have a significant degree of inflammation of their adenoids. That can cause basically an obstructive sleep apnea. A lot of times if you ask the patient or ask a bedfellow or ask parents, you'll find out that the child is snoring. Manifestations will often vary based on age, so it really depends on how old the child is. If this is a very, very young child, a baby, it may be manifested as sniffling or snorting, although we tend to not see allergic rhinitis in babies. But if it's a very, very young child, it may manifest rather than nasal itchiness, it may be just sniffling or snorting. In older children, it'll generally be more of the classic symptoms that we see in adults as well, and that would be things like nose blowing and itching. In particular, here we're talking about with nasal itching or the scratch response to relieve that itchy feeling. It's that allergic salute where the patient will take their hand and rub their nose that way. And ultimately that causes that transverse nasal crease. And then what we saw with this patient was that the symptoms can improve with the use of over-the-counter decongestants or antihistamines. There are so many antihistamines and decongestants and things to relieve allergy that are over-the-counter on the market, and invariably, because knowledge of allergy is so prevalent in the lay population, it's very typical that a patient will have used one of these drugs, one of these remedies, to some avail if they have allergic rhinitis. And it's very classic that you have a patient with these symptoms and you ask them, have you used Claritin, have you used Zyrtec, have you used Zicam? And if they say yes, then that points you towards allergic rhinitis as opposed to something like a viral upper respiratory tract infection or sinusitis or something like that. Important things to ascertain. Of course, with any allergic process that we're considering, you want to know, are the symptoms better or worse during certain times of the year? Not only is that going to point you towards whether or not this is an allergic process, but it can also point you towards whether or not this is seasonal or perennial if it is an allergic process, and that can help you narrow down the list of possible offending allergens. You also want to know, is it any better or worse at certain locations? So, like I said, if you go to Aunt Martha's house where she has birch trees or she lives in a rural area, you may have a worse time there than you have if you're living in a nice, sterile, suburban environment where you're less likely to be exposed to allergens. If you go to a cousin's house where they have cats and carpet and all that sorts of things, that can make it worse. So you want to know, if you can, are there places where it's worse or where it's better? We already talked about this, but does anything make the symptoms better? Particularly here we're talking about over-the-counter medications. You want to know, does the discharge have any color? Typically with allergic rhinitis, the discharge is clear, and that goes for allergic conjunctivitis as well. The discharge is going to be clear. It's not going to be purulent. The consistency is usually stringy or watery as opposed to thick and purulent and mucoid. Is there a family history of allergy or asthma? If a parent is affected with allergy, one parent, there's a 50% chance that the child is going to be affected with similar allergy. If it's two parents, that risk goes up to about 2 and 3, 66%. Are there any other symptoms? So if this child had presented and he also had a fever and a cough, that would point you towards possibly flu or common cold compared to allergic rhinitis, which typically with allergic rhinitis the symptoms are non-systemic. They're focused on the nose and possibly the eyes. We're going to see that there's there's comorbidity with allergic rhinitis. A lot of these patients will also have allergic conjunctivitis to one degree or another. And then you want to know things about the home environment. So a child who lives in a house where there's carpet and cats in a rural environment is going to be much more likely to have allergy than a child who lives in a home where there's hardwood floor and no pets and lives in the suburbs where they're not as exposed to weeds and pollen and things like that. So a physical exam is going to be useful to investigate for the possibility of non-allergic causes or comorbidities, which there are a lot. So things we want to look out for are other things that give you a similar picture to allergic rhinitis. We want to look out for asthma. Typically, you'll have wheezing there, eczema. That should be apparent based on physical examination, looking at the skin. Cystic fibrosis. In a lot of cases, you can get something that looks like allergic rhinitis because they develop nasal polyps, and that's an obstruction of the nose, which can lead to sort of stuffy nose feeling, and can also cause a runny nose. If you get because you get obstruction around the nasal passages. And then adenoidal hypertrophy, again, something that can result from chronic allergy, and it can also be something that masquerades as allergic rhinitis, again, because of the obstructive nature of it. Classic findings of allergy are common in allergic rhinitis. We saw this in the patient that we saw in the vignette. So allergic shiners, that's those dark circles beneath the eyes, sort of puffy lower eyelid area. The Denny lines, those are lines that run from the inner canthus along the lower eyelid. They're pretty discrete, they're bilateral. And then the transverse nasal crease, which is a result of doing that allergic salute. Other things you want to look for are things that are consistent with allergic conjunctivitis, which often coexists with allergic rhinitis. We saw that to some degree with this patient, at least on history. So you'll look for chemosis of the conjunctiva, you'll look for erythema of the palpebral conjunctiva, and then you'll look for watery discharge. You also want to look on just in your general physical exam, look inside the ears. You can look for signs of chronic infection or middle ear effusion. You take a look certainly inside the nose. What you would see in allergic rhinitis would be enlarged turbinates. I'll show you some pictures of that. Edema of the mucosa. The mucosa will tend to be pale. I've heard it described as gray or blue, but to me it looks awfully pink, if you ask me. But what's most important that you get from that is that it is pale, and it's pale because the mucosa is edematous, and so it's going to spread out the vessels, and it's going to look more pale in appearance, as opposed to something else that we see that causes rhinitis, which is rhinitis medicamentosa, which is a rhinitis that you get after you've taken nasal decongestants for a period of time. That will give you more of a red, meaty mucosa in the nose, as opposed to this paler, bluish, pinkish, pale-colored mucosa that you see in allergic rhinitis. The discharge will be clear. It may be tinged with blood. If it's tinged with blood, that's probably due to the fact that these children are rubbing or picking their noses. That can cause some trauma and lead to a little bit of blood, but it obviously shouldn't be frank blood. But you can see some blood streaked discharge. That's not unusual at all and certainly doesn't rule out allergic rhinitis. Also good to look inside the nose, because if you were to see polyps, that's going to warrant a workup for cystic fibrosis. All right. If you look inside the mouth, you may note malocclusion or discoloration. That's consistent with chronic mouth breathing. Who wants to be a mouth breather? But mouth breathing is something that you will see in patients with chronic allergy, particularly rhinitis, because you get that obstruction from the edema. They then breathe through their mouth, and that can cause things like malocclusion and discoloration, as I mentioned. If the patient has adenoidal hypertrophy, it's really difficult at that point to determine whether that's adenoidal hypertrophy due to allergy, which can manifest as allergic rhinitis, or if that's adenoidal hypertrophy due to some other chronic inflammatory process, which can then cause symptoms that look like allergic rhinitis. But it's useful to document that. So this is the allergic salute here. And then we can see various things on these pictures. This patient lower left here has your classic allergic shiner beneath this left eye here. This child has allergic shiners. You see that sort of bluish, grayish kind of color beneath the eyes. This patient on the lower left and on the lower right here, they both have these Denny lines, which run underneath the lower eyelid. Also, of note that all of these patients, not the baby necessarily, but these patients all have long eyelashes. That is commonly seen in patients who have chronic allergic conjunctivitis, which, remember, it coexists with allergic rhinitis. So that may be the reason why all these patients have nice long eyelashes. I was always told when I was growing up, I'll never forget when I was in 7th grade, a girl told me, "Paul, a girl would kill for your long eyelashes." I didn't know whether to take that as a compliment or as an insult. I do have allergies, by the way. Okay, so this is a normal view via rhinoscope anterior rhinoscopy of the nasal turbinates. So we have the nasal septum here, the inferior turbinate, and the middle turbinate. And this is very nice. You get a good view of the nasal passages here, as opposed to these pictures, which I'm going to show you, where you see significant inflammation. So here the inferior nasal turbinate is bulging outward. It's edematous, it's pale, so compare color. It's always hard to know, because just by looking at these pictures you don't know where the light is and stuff, but you notice that the color here is roughly consistent with the oral mucosa, what we would expect out of oral mucosa at least. Here you see it's a little bit more pale. You also see the secretions and the bogginess of these turbinates as well. Okay, so this is even more obvious. You see the paleness and the edema. What do we do for diagnosis? So this is typically a clinical diagnosis. As long as it's a very straightforward presentation, you can make the diagnosis clinically and jump right to treatment. However, in more complicated or severe cases where alternative diagnoses can't be sufficiently ruled out, you can do diagnostic testing for allergic rhinitis. Now, diagnostic testing for allergic rhinitis is really the same as our diagnostic testing for any kind of allergy, be it conjunctivitis or atopic dermatitis. And so what we're going to do is either the allergen skin testing, in which we can test, this is usually our go-to test, but you can test for specific allergens, outdoor allergens, indoor allergens. You can also do RAST or allergen ELISA. There's been a trend towards doing the allergen ELISA as opposed to the RAST, but this is our in vitro testing of choice for determining the cause of the allergy. You can also get a CBC, which would show eosinophilia, and then a nasal smear, which can also be done. That would also show eosinophils, excess eosinophils in the nasal secretion. are differential. So there are a lot of things that can cause a runny nose, and so it stands to reason that there are a lot of things that you need to consider when you have a patient that comes in with a runny nose. Vasomotor rhinitis is probably the most common thing overall. Maybe not the most common presentation, but the most common thing to cause a runny nose in general. So, for instance, the room I'm sitting in, I'm freezing cold. It's 60 degrees in here, roughly, but my nose is slightly runny. That's vasomotor rhinitis. So that can be caused chiefly by a cold environment. It can also be caused by spicy foods or warm foods. So if you have a nice hot burrito with a lot of what's that good sauce, that Cholula sauce that they put on hot Mexican food, that's certainly going to trigger a runny nose. Chemical irritants, perfumes, smoke, that can cause your nose to run. And then certain medications, aspirins and NSAIDs, probably chief among them, can cause a runny nose. Rhinitis medicamentosa, nice Latin word for you. This is caused by the recent use of decongestants, or what I should say is the recent use of decongestants for a period of time, usually around 5 days to a week, followed by the sudden cessation. You get a rebound effect, and this is just your rebound rhinitis. And so if you use Zicam for a period of time and you stop, that can cause this rhinitis medicamentosa. You'll be able to differentiate this based on history, and then when you look inside the nose, typically what you're going to see is more of a beefy red mucosa as opposed to a pale mucosa. Infectious, chiefly viral rhinitis, you'll typically see other symptoms of upper respiratory tract infection, so things like sinus pain and congestion. You may also note findings in the upper respiratory tract like crackles and wheezes and rales. Hormonal rhinitis can be associated with pregnancy, oral contraceptive use, and hypothyroidism. Not something that we would have considered in this child simply because he didn't have, well, he was a boy, he can't be pregnant. Hopefully he's not on oral contraceptives, although you can never rule out young kids getting into mom's oral contraceptives, I suppose. But then he didn't show any signs of hypothyroidism here. Non-allergic rhinitis with eosinophils, or aptly named NARES, N-A-R-E-S, looks just like allergic rhinitis, with the exception that no allergic source can be detected with RAST or skin testing. So this is a strange one. It really masquerades as allergic rhinitis, but the only difference here is that if you were to do extensive workup looking for a potential cause, you would find none. So you would find no allergen on skin testing. Luckily for us, that we really don't need to differentiate this from allergic rhinitis because it responds to the same treatment as allergic rhinitis. So that really kind of helps us, gets us off the hook at least. Anatomic or structural problems can include things like septal deviation, nasal polyps. A lot of times this is easy to exclude just on a good anterior rhinoscopy. Remember though, nasal polyps in children, not common. You can see them in adults, but nasal polyps in children is not common. If you do see a nasal polyp in a child, you're going straight for a cystic fibrosis workup. That's a good nickel's worth of free advice for the USMLE. Child plus polyps equals cystic fibrosis until proven otherwise. Brr, it's really cold in here. Okay, so this is a sort of an algorithm that I found online. So a patient presents with rhinitis, you want to know, is this acute? Has it been happening for 1 week or less? If the answer to that is no, then you want to know, are there chronic symptoms, namely symptoms of allergy? If the answer to that is no, then you can do various approaches. What they recommend here is trying appears what they're saying is a trial of decongestants or nasal sprays or steroids with or antihistamines, and then see if you get a response from that, or you can go ahead and do a test. If the answer is yes, that they do have chronic symptoms of allergies, then then you can go about diagnosing allergic rhinitis either clinically or I suppose you could do testing too. This is just a suggested approach. You certainly don't need to adopt this if you don't want to. But then they also advise you if the symptoms are acute, if it's been happening for a week or less, that you get whether or not this patient has a history consistent with viral infection, upper respiratory tract, etc. So this is an approach you can take or leave if you want. So what do we do for management? If you looked at my general allergy lecture, you'll see that the approach to allergy is two-pronged. It's exposure reduction and then pharmacotherapy. Generally, we're doing both. Theoretically, you could get by with exposure reduction alone, but for most patients, they're going to continue to have symptoms just because a lot of these allergens are just omnipresent. So you can go ahead and do sealing of mattresses and pillows with a hypoallergenic casing. Remember that one of the big culprits of allergens is dust mites, and those live in your bed. So if you seal the mattresses and pillows off with this casing, it should reduce your exposure to dust mites. Frequent washing of bedding and clothes is useful. So for the bedding, it helps get rid of those dust mites. For the clothes, remember that your clothes can track in all sorts of allergens, either from pets. You can get pollen attached to your clothes or weed dust attached to your clothes, and so that can happen too. So you should frequently wash your clothes as well. And the recommended temperature is above 150 degrees Fahrenheit, so warm water, and that's primarily to kill the dust mites. Showering and shampooing is useful for a similar reason as to why we wash our clothes. So you come in from outside where there's grasses and pollens and all that stuff. You should, before going to bed, take a nice shower and shampoo and soap down. That's going to get rid of those allergens that may continue to be on your skin. Because remember, if you have allergens on your hands and you go to rub your nose, now you're introducing all those allergens to your nasal passages. Certainly don't need to do temperature more than 150 degrees there. I would advise against that. But nice warm shower never hurt anybody. Remove or limit exposure to source. That primarily here I'm talking about pets. So removing a pet from the house is an option, certainly not a rule, and it's really not emotionally feasible for most people. So the recommendation is to just sort of have the child's bedroom be pet-free. Don't sleep with the pet. I'm guilty of having my dog on my bed. Probably shouldn't, considering that I have allergies. But I'm just a shining example that patients don't always respond to what's recommended. But anyway, I talk about this in the general management of allergy section, so you can get that in greater dosage there. Pharmacotherapy. What do we do as far as treating them with medications? Well, a lot of this is over-the-counter stuff. So in many cases, we can tell them to keep going with that if the diagnosis is allergic rhinitis and they respond to over-the-counter Claritin or over-the-counter Zyrtec, then certainly by all means, if that helps, you can continue that. There are prescription strength therapies that can be done, and you can go towards that if the over-the-counter stuff doesn't seem to be clearing the symptoms. So for instance, in this patient that we had in the vignette, the over-the-counter Claritin helped sometimes, but other times didn't. So maybe he would be a candidate for a more prescription strength medication. So some of the second generation antihistamines you can get over the counter are things like cetirizine, which is Zyrtec, loratadine, which is Claritin, fexofenadine, which is Allegra. That's usually the second generation antihistamines are the first line of pharmacotherapy in allergic rhinitis. We try to avoid the first generation antihistamines in children, well really anybody. Second generation tend to be preferable because they don't cause that somnolence. However, if it's not a school night, for instance, or if the allergies are keeping the child up at night, then you can go ahead and use something like Benadryl, where it is going to cause somnolence, but it's also going to help with sleep too. You can kind of kill two birds with one stone. For more persistent symptoms, then we tend to go towards these intranasal preparations. You can use intranasal corticosteroids, which include beclomethasone, and beclomethasone is marketed as Beconase, triamcinolone, which you see over the counter as Nasacort, or fluticasone, which we see over the counter as Flonase. And then intranasal ipratropium, this can be used as well. This is a nice way to avoid using those corticosteroids. I'm not sure if you get the rhinitis medicamentosa by cessation of ipratropium, but this is Atrovent, and this is available as a nasal spray. Nasal saline irrigation can be useful adjunctively. So that's those neti pot things that you can get. Again, they're over the counter, and you kind of flush out the nares and the I don't know how far back it goes, probably back to the pharynx, and then I'm not sure to what degree that's going to be feasible in a child because it is kind of uncomfortable. But that can be used adjunctively in a child that will comply, or in an older child or an adult. Okay, so other things that can be done. I have seen that, and I'm not a pediatrician, but I have seen that pseudoephedrine can be given to children, I believe, over the age of 2 or 3. I would personally not want to provide that to a child if I could avoid it, just because of all of the adverse effects, and because we have these antihistamines and these intranasal preparations that are just as effective. In general, you want to avoid nasal decongestants, especially in patients that are going to be using them frequently, because we want to avoid that rebound rhinitis. Complications. So our complications can be due to many things. So those that are related to obstruction can include acute or chronic sinusitis, middle ear effusion, and recurrent or chronic otitis media. Those related to allergic inflammation, again, coming up here is our adenoidal hypertrophy. That can be a masquerader of allergic rhinitis. It can also be due to allergic inflammation. Those related to medication use, already talked about rebound rhinitis, and then those associated with other allergic diseases. So we have asthma. And with asthma, there's a high coincidence, so up to 78% of asthma patients will also experience allergic rhinitis, and about 38% of allergic rhinitis patients will have asthma. So important, very useful, at least in any child that comes in with a new diagnosis of allergic rhinitis. Keep an eye on them for asthma. At least get a nice pulmonary physical. Certainly you don't need to do formal testing, but get a nice pulmonary physical, educate the parent about asthma and how it may present. If the child has wheezing or difficulty breathing, bring the child in right away. And then exacerbation of one. So if the allergic rhinitis is exacerbated, then you have an increased likelihood of having an asthma attack, and vice versa. Patients who have asthma attacks are going to be more likely to have symptoms related to allergic rhinitis, and that's probably due to the fact that it is exposure to the allergen that can cause both. Treatment of one is also associated with relief of the other. So if you have a child who has asthma and they have symptoms of allergic rhinitis, very useful to treat their allergic rhinitis because it will decrease their likelihood of an asthmatic attack. What is the prognosis? Well, this is really not a malignant disorder. So most patients are able to live normal lives with their symptoms of allergic rhinitis, and they do fine with just care as needed. So using their Allegra or using their Flonase spray, and they're typically fine with that. There is a cure, quote unquote cure, and I use that with quotes. That's allergen immunotherapy or allergy shots. The reason that I use this in quotes is because it has been shown that once you stop the immunotherapy, it only takes a few years and you can actually develop allergic rhinitis again. And usually allergic rhinitis is not something that's problematic enough to where a patient's going to even want to get that series of allergy shots. Remember, the allergy shots, you have to come in several times every week for a period of time. And so for some patients that just might be overkill. A small percentage of patients will experience long-term resolution in adolescence. However, the majority of them will have this throughout their lives, and it'll just be something that they have to manage with either over-the-counter medications or with prescription strength medications. However, symptoms do begin to wane in mid-adulthood, but it never really resolves completely. It just gets a little bit better with adulthood. And that's a pattern we tend to see. Allergies are a little bit worse in children than they are in adults. But everybody's susceptible to allergies. You'll see them in the adult population, in the geriatric population, and you'll see them in children as well. Really, the only people who don't have allergies that bad are neonates. And even in very, very young babies, we can see things like atopic dermatitis. And as we're going to see when we talk about atopic dermatitis, that is a herald. They call it the March of Atopy. That's a herald of things to come. And those patients will typically have allergic rhinitis, allergic conjunctivitis, and then go on to develop asthma and things like that. So if you have any questions, go ahead and write me a note below. Otherwise, I will see you on our next lecture.